Good morning, everyone, and welcome back to BSN 620. Today, we're going to be learning about anxiety and related disorders. So, I want you to take a moment to think about what your understanding about the difference between everyday stress and an anxiety disorder might be. Of course, as we go on with today's lecture, you'll be able to distinguish between the two, especially by the end. But just to set the foundation for what we're going to be talking about today, take a moment and think about what this question is asking. And to take it a step further, I want you to think about how can the same response that helps us escape danger be the reason someone feels trapped in their own mind? So there's no right or wrong answer that I'm looking for here because it is subjective. You might have thought about fight or flight, which we'll learn about as well. But you have probably heard about this term from other courses. It's an evolutionary response where our body reacts in a way so that it can protect us from immediate danger. So we have stress hormones that are released so that we can react quickly, whether it's a perceived threat or a real threat. So we're preparing to either fight back or to run away from this threat. However, as we're going to learn today, when we have anxiety and other anxiety disorders like panic attacks, PTSD, the same system that is designed to protect us from danger becomes overactive. It becomes chronic. And our body's alarm system can't distinguish between real and perceived threats. So someone could become, quote unquote, trapped in their own mind, trapped in their own body, because the body is reacting as if they're in danger, but there's no way of escaping it because this danger is internal. It's associated with our thoughts, our feelings. So like I said, there's no right or wrong answer, but start to think about that, the fight or flight response, and then what might happen and what you might know about anxiety. And it is a paradox because what protects us can also imprison us, right? Fear keeps us alive. However, it can also limit how we can fully live our lives to the fullest potential, as we're going to learn when it comes to anxiety and the challenges people might experience. So we know that there is normal or quote unquote normal anxiety or a healthy level of anxiety. And this is a healthy reaction. It is necessary for our survival. And anxiety is a universal human experience, right? It's one of the most basic emotions. And you might feel normal anxiety as a student when you're studying and preparing for a test. You might feel butterflies in your belly. You might feel a little bit nauseous thinking about, oh, am I going to pass? Am I going to do good on this test? Did I study well enough? Do I know the answers? Maybe you're preparing for a job interview and you're a little bit apprehensive. Am I running late? Am I going to get there on time? Am I appropriately dressed? Do I look professional? Did I get this job? Did I answer the questions right? So these are just some examples of everyday normal anxiety. But when we're talking about anxiety as a disorder from a mental health perspective, it's really this feeling of apprehension, this uneasiness, this uncertainty, and even this dread that might result from either perceived or real threats. And like I said, our brain can't always distinguish between a real and a perceived threat. So, whereas anxiety is a vague sense of dread that's related to either a unspecified or an unknown danger, fear is a reaction to a real or perceived danger. And there are different levels of anxiety that we're going to learn about. So we have mild, moderate, and severe. When it comes to mild anxiety, this occurs in the normal experience of everyday life, right? This allows us as individuals to really perceive reality in a sharp focus. So, some of the things that I mentioned, right? We might feel slightly nervous before a big event, but we're still able to function normally and attend that event. We can prepare in advance. We might feel some restlessness, some irritability, and we might even utilize some tension relieving behaviors, such as fidgeting or nail biting. But overall, we can still go about our daily activities. Then we move into the realm of moderate anxiety. And the person that's experiencing moderate anxiety, they see, hear, and grasp less information from their surroundings, and they may even demonstrate selective inattention, in which only certain things in the environment are either seen or heard unless they're pointed out to them. So this can inhibit clear thinking and even problem solving. So your perceptual vision really starts to narrow as we move up into the levels of anxiety. So here you might find it hard to concentrate because of the constant worry. You might have palpitations. You might feel an increased pulse and respiratory rate. You might even be sweating. And you might even experience some mild somatic symptoms, so physical sensations related to the anxiety. The nausea, even feeling like your stomach is hurting, your stomach is upset. Sometimes diarrhea can even happen. So as we're moving up, our perceptual field is starting to really become reduced. As is the case with severe anxiety, your perceptual field is greatly reduced. And a person that is experiencing severe anxiety, they may only be able to focus on, say, one particular detail, or they might have scattered details, and they might have difficulty noticing what's going on in their environment. And this is because the person is experiencing significant distress. Learning and problem solving might not be possible. And this is where the automatic behavior really kicks in, such as pacing and wringing of your hands and constant fidgeting. And this is aimed at reducing or alleviating that anxiety that you're feeling. It's an automatic reaction from your body. So some of the symptoms might be this debilitating fear. You might experience more somatic symptoms. There is a significant disruption of your daily life because of the anxiety. You might even avoid certain situations, certain people because of this pervasive fear and this worry. And you might feel this sense of impending doom, that something bad is going to happen, something is not right. Panic, on the other hand, this is the most extreme level of anxiety, and this results in noticeably disturbed behavior, where the client is unable to process information, and sometimes they might even lose touch with reality. So they might experience a little bit of psychosis. They might even experience hallucinations or false sensory perceptions, as we've defined them in the previous couple of weeks. So here the person might be pacing. They might even feel like they need to run away from their surroundings. They might be shouting. They might be screaming. Or they might even withdraw into themselves. They want to be isolated. They don't want to talk to anybody. Their actions can also seem a little bit erratic, impulsive, uncoordinated. Sometimes people that experience a panic attack just want to curl up into fetal position. They want to go inwards. They want to withdraw. Like I said, other people might want to run away from the problem. And by problem, it could literally be something in their mind. It could be a trigger in the environment. Sometimes you don't even know what it is. You just feel like, I need to get out of here. I need to run away from wherever you are. So the symptoms really do vary depending on the person. And here I have a little bit of a question for you. So, if you're a parent shopping with your 5-year-old child in a very large, busy urban mall, all of a sudden you realize the child is missing, which level of anxiety would most likely be what you're feeling? Is it mild, moderate, severe, or panic? So, the answer is most likely you would feel panicky. And what behaviors might this parent exhibit that would indicate panic level anxiety? So take a moment to think about that. But really, maybe the parent is pacing, maybe they're running, trying to look for their child. Maybe they're shouting and screaming their child's name, or they're saying their child is lost. They're trying to get attention from their surrounding, peers or whoever is in their vicinity, so that they can help find the child. Their physical behavior might even be erratic. They might be impulsive, because this is an extreme level of stress where you've lost a child, you've lost this little human. So when it comes to the body's defenses against anxiety, we're really referring to what we call defense mechanisms. So these are the automatic coping styles that protect us from anxiety and really help us maintain our self-image by blocking feelings, by blocking conflict, or by blocking memories even. And these defense mechanisms are an unconscious and automatic process that happens. And the purpose is to protect ourselves from these anxiety-provoking thoughts, from these anxiety-provoking feelings and situations. So it's really our brain's way of protecting ourselves from this real or perceived threat. And it was Sigmund Freud and then I believe his daughter Anna Freud that really started to coin these terms and define what type of defense mechanisms we might be exhibiting. So some examples, and your textbook lists them for you as well. Denial is an example of a defense mechanism, right? So say somebody passes away and your reaction is to refuse to accept this painful truth. No, this cannot be real. There must be a mistake. I just saw this person. This cannot be real, right? You're lying. Rationalization is also an example of a defense mechanism. So here we're creating a logical but false explanation for behavior that would otherwise be unacceptable. So say you go to the bank and you applied for a loan because you want to buy a house. And you go to the bank and they tell you that you are denied this loan. So in rationalization, you might say to yourself, you know what, I didn't really want this house. It was way too big for me anyways, right? So you're creating this logical but almost false explanation to ease your anxiety. Another example is displacement. So you take out your frustrations on a less threatening person or a less threatening object instead of the true source. So say you had a really bad day at work or a really bad day at school, and instead of getting upset at your manager, you go home and you get angry at your spouse or at your children because they are a less threatening person, and you're taking your frustrations out in that way. So as I mentioned, your book gives you some other examples, but these are just some examples I wanted to share of defense mechanisms. So ways that your brain protects you against this perceived or real threat. And these defense mechanisms can be what we call adaptive or healthy, where they actually assist in lowering your anxiety and achieving goals. Or they can be maladaptive or problematic or unhealthy, because you think it's going to actually try to lower your anxiety, but in fact, it's causing more problems. It's more of an unhealthy way. So I have some examples here. I'm not going to go through all of them, but you can take a look. So when we talk about adaptive defense mechanisms, the situation I presented is a nursing student fails an important exam. So there are various defense mechanisms that can be automatically utilized in this situation, and that depends from person to person. So one example is humor. So the student jokes, well, guess I'll be the most educated student retaking this class. And here, the humor as a defense mechanism is actually helping relieve that anxiety. Sublimation, the student channels their frustration into studying harder or helping classmates prepare for the next test. So here, you're actually redirecting your negative emotions into productive behaviors. So adaptive mechanisms are assisting you to lower your anxiety and achieve your goals in a healthy, more acceptable manner. The maladaptive mechanisms, they are a bit more problematic or unhealthy ways. So same example, nursing student fails an exam. So displacement is a third one. The student goes home and yells at a family member out of frustration, right? So they're transferring their anger from the source, which is failing the exam, to a more safer target. Or there's projection. The student blames the instructor. They didn't like me, that's why I failed. Or they didn't explain the content properly, so I didn't understand it, right? So once again, these are problematic ways that you can try to utilize to lower your anxiety. So now we're going to get into anxiety disorders. And the disorders listed here for you are the ones that we are going to go over. So when we're talking about anxiety disorders, it's really this excessive fear that comes from your altered perceptions and behavior. So your mind and body perceive either a real or a perceived threat, and your system goes into overdrive. So we're going to be learning about all of these in detail. So just wanted to start off with a little bit of statistics. So anxiety and anxiety disorders are actually the most common form of mental health disorders in Canada. And in 2021, worldwide, there were 359 million people that were living with an anxiety disorder, which includes 72 million children and adolescents. And I'm sure, as we are aware, and we can even reflect back, during the pandemic and even after the pandemic, mental health conditions increased, especially when it comes to anxiety. So in the initial year of the pandemic, there was a massive 25% global increase in anxiety and depression, right? So even thinking back to what was going on during the pandemic, there was a lot of fear, there was a lot of worrying. First, we didn't know what was going on. Then all these protocols were being put into place, and we had to change our lives to fit into these protocols. Physical distancing, the vaccines, dealing with the symptoms. A lot of people passed away because of COVID. The isolation, not being able to see people. Humans are social beings. So it's not a surprise that there was an increase in anxiety and depression. And women are affected by anxiety disorders more than men. That doesn't mean that men don't experience anxiety disorders. They do. And 1 in 4 Canadians will receive a lifetime diagnosis of anxiety. So it definitely is on the rise. And as we're going to learn when it comes to the factors, there's never one reason why anxiety or mental health conditions are on the rise, but even start to reflect on why are anxiety issues on the rise, right? Look at the type of lifestyles we live. Everything is go, 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 rush, rush, rush. We have to succeed. We have to get to the next level of our goals, the next achievements. That mindfulness, that being present, that slow life is no longer the reality. So maybe that is attributing to this increase in anxiety. So when it comes to anxiety, as we're going to learn, especially when we talk about depression next week, oftentimes anxiety can occur with depressive disorders, but it can also occur with other psychiatric conditions as well. So, like I mentioned, there's not one known reason why someone might have anxiety. There are a combination of factors, right? There could be biological factors. So, there are some theories that say that anxiety disorders often run in families. There might be certain genes that can increase your vulnerability, right? Your neurobiological factors. So, there can be dysregulation of neurotransmitters like serotonin, norepinephrine, and even GABA that can result in this overactivity, this hyperactivity in your brain. There can be social factors. Individuals might experience traumatic life events like abuse, neglect, bullying, racism, accidents, even disasters, right? Like natural disasters. All of this can trigger or even exacerbate anxiety disorders. Chronic stress, unstable family environments, grief, loss, this can also increase anxiety disorders. When it comes to psychological factors, the psychodynamic approach or reasoning is that anxiety can also arise from unconscious conflicts. Maybe there's some repressed trauma and all of a sudden it decides to come out, maybe because we didn't deal with it in a healthy way before. Behavioral is saying that anxiety is also learned. It's a learned behavior through conditioning, right? Say you grow up in a household where anytime there's a stressful situation, you see your parents or your caregivers visibly become really stressed out, visibly become anxious. They're pacing, they're sighing. Oh, here we go again. Something else is going wrong. So then you are also learning how to react in certain situations based on what is going on in your surroundings, based on how other people are also behaving through conditioning, right? Environmental factors. So there can be some prenatal exposure to toxic, chemicals, for example, such as alcohol or even drug exposure, right? That can affect fetal brain development and stress regulation. Adverse childhood events. There are socio-cultural factors as well. So we did speak previously about culture-bound syndromes. Essentially, in some cultures, anxiety disorders, they manifest in a culturally specific way that might not fit neatly into the Western psychiatric diagnosis, right? So these symptoms reflect how the culture understands the expression of anxiety, how the culture shapes the interpretation and the meaning of the anxiety. So all in all, we need to know that there is not one known cause. There are a combination of factors that come together to produce this anxiety disorder in someone that's beyond the normal everyday anxiety that we experience to keep us in survival mode. So now we're going to get specifically into some anxiety disorders. So this acronym, as silly as it sounds, PASS, GAS, is one of the ways that you can remember the specific anxiety disorders that we are going to be talking about. So I'm not presenting this in the order of that acronym. That acronym was just designed to help you remember. So we're going to start with generalized anxiety because I wanted to start with more broad and then really move in and narrow down. So when it comes to generalized anxiety disorder or GAD, here we're talking about persistent, uncontrollable, and irrational worrying. So this could be about school, work, health, finances, other life factors, and other life situations. So the client is in this constant state of worry, fear, and even dread, and it does impact your daily functioning. So the individual's anxiety is out of proportion to the true impact of the event or the situation about which they're worrying. So this could be some worry related to school or work or health or their finances. So this anxiety is out of proportion to what in reality is actually happening. So the signs and symptoms do vary, but there are psychological symptoms that a client might experience. And this also occurs with the other anxiety disorders that we're going to be learning about. So the client might experience poor concentration. They're not able to make decisions, poor problem solving. They might have racing thoughts where one thought goes from one to the next, to the next, to the next, to the next. So you're not able to rationalize your thoughts because they're moving so quickly. It's that anxiety, it's that worrying that's causing your thoughts to jump from one to the next, to the next, to the next. You can also experience physical sensations related to anxiety as well. And that's really important to know because sometimes clients might not realize that the physical sensations they're experiencing are not because of a primary medical disorder or a physical disorder, but it's in fact your anxiety that's manifesting as palpitations, as a difficulty in breathing, as a headache, a migraine, insomnia, difficulty falling asleep, staying asleep, stomach aches, unexplained aches and pains, the need to use the washroom frequently, right? Irritability, restlessness, fatigue, even oversleeping, right? So the signs and symptoms do vary, but knowing that there are psychological and physical symptoms as well as behavioral symptoms to anxiety is very key. And by behavioral, I mean, if we think about those maladaptive and adaptive ways, avoidance is a key behavioral symptom that the client might experience. So you feel anxious about a certain situation and you want to avoid that so that you don't feel this anxiety. But the more you avoid it, the more your anxiety is going to actually increase. So you think this is helpful, but it's actually a maladaptive practice. And when it comes to the treatment of generalized anxiety, and this also applies to the other disorders we're going to learn about. For anxiety disorders, the treatment typically is psychotherapy in combination with medication. So this is also going to vary. Some people don't need medication or they don't want to take medication. Or they in fact don't need medication because they can manage using relaxation techniques. They can manage using support groups. They can manage using psychotherapy. And there's nothing wrong in taking medication. Sometimes the client needs to be able to clear that mental fog, to relax their overactive system, to be in a more calm state where they can think clearly, they can focus, where, they're not as restless, so that you can actually be in a calm state to then actively and effectively participate in psychotherapy. So with psychotherapy, it's specifically cognitive behavioral therapy that is known as the golden standard treatment for anxiety as well as depression. But of course, there are other modalities of psychotherapy as well. But here, we're really learning to identify our thoughts, these automatic negative thoughts that we have, and reframing those thoughts, challenging these maladaptive behaviors that we have. And this is going to change how we're feeling, which is then going to hopefully change how we're behaving and acting. So psychotherapy, particularly CBT and medication, do work very well together. And sometimes people might not see the value in psychotherapy for anxiety, but one of the ways that I can explain it, or I usually explain it to clients, is that say you start to take medication and it, eases your restlessness, it eases the palpitations you're having, you're able to concentrate a little bit more. But then you go back to living in a maybe unhealthy environment. Maybe there's conflict in your home. People are always yelling. It's not a safe environment. You're not able to set boundaries. You're not able to stick up for yourself with what's going on in your home environment. The medications are not going to fix your psychosocial factors. The medication is only helping you with your physical body, right? The therapy can help you figure out how to manage the psychosocial aspect. Do I need to set boundaries at home? Do I need to remove myself from this toxic environment? Do I need to, limit my exposure when there's yelling at home, for example? So that's a very simple example of how therapy and medication can work together. The medication is not going to fix the other factors in your life. That's what psychotherapy can help you with. It can help you talk to someone that brings a neutral perspective into the mix, that helps you see things from a different perspective and helps you challenge your negative automatic thoughts. So last week, or week 5, we spoke, or rather the lecture was about psychotropic medication. So it's helpful to review that lecture as well on the different types of medications for anti-anxiety. So typically a client might be given an anti-anxiety medication such as a benzodiazepine. They can also be started on a antidepressant such as SSRIs, because the SSRIs, they reduce the excessive worrying and the fear and this hyperarousal, and it really helps to normalize the stress response, which over time can also reduce your physical symptoms like palpitations and sweating and muscle tension, which can then improve your coping and your emotional regulation, right? So I would encourage you to review anti-anxiety medications, antidepressants, because they are part of the treatment for anxiety. So we have panic disorder. So here it's a sudden onset of extreme apprehension or fear, and the client might feel this impending sense of doom. And typically it's a sensation of feeling that comes out of the blue. So it's not necessarily in response to an immediate trigger or an immediate stress, right? You might just be watching TV, minding your own business, and all of a sudden you're in a full-blown panic attack, right? Maybe something triggered this panic attack out of the blue, but in your immediate surroundings, you couldn't figure out, well, I was just watching TV. What happened? right? So that's what that sudden onset is usually referring to. And the sensation can be so overwhelming that to some people, it feels like it's a heart attack. So you might have some people end up in the ER because they have this um, heaviness in their chest. They have difficulty breathing. They have palpitations. They're sweating. So then they might think, oh my gosh, I'm having a heart attack, and they end up in the ER. When in fact, after all the tests, discussions, assessments, they realize it's in fact a panic attack. Oftentimes, people might even feel like they're losing their minds, right? They're having difficulty breathing. They can't concentrate. They can't focus. They just want to run away. They want to go in within themselves. They want to withdraw. So they feel like they're losing their minds. Um, and fear of having another panic attack can also limit your daily life, which can then cause more panic attacks. So it's like this negative feedback loop that's happening. And essentially, the panic disorder is an overreaction to your body's physiological response to this perception of real or perceived danger. So, in a normal response to anxiety, your brain perceives danger, which is going to stimulate your sympathetic nervous system, and then you're going to release adrenaline. You have an increased heart rate so that blood and oxygen go to your brain and it goes to your muscles so that you can be ready to fight or flight, right? Fight or run away from this perceived or real danger. But in a panic response, this physiological response is exaggerated well past what is useful. So you have the heavy breathing, the hyperventilation, the racing heart, the changes in blood flow, which can result in numbness in your hands or your feet and this lightheadedness almost. So it's this maladaptive response to this once healthy, helpful physiological response. And the treatment is also similar to GAD, so psychotherapy, medication, relaxation techniques, support groups, identification of what your triggers are, what your coping strategies are, what you can do, and all of this you can develop through psychotherapy. Next, we have phobia. So a phobia is this persistent, irrational fear of a specific object, activity, or situation. And this leads to avoidance. So you can avoid the actual object, situation, or activity, or you have this desire to avoid it, despite the awareness and reassurance that it is not dangerous. So for example, there are plenty of phobias. There's the fear of heights, for example, the fear of spiders, arachnophobia, right? It's an irrational fear. You know logically that the spider can't really hurt you. Yes, I know there are poisonous species, but rationalizing, we live in Canada, we live in Ontario, we live in the suburbs. Are there poisonous species? No. So rationally, you know it. But when you see that spider, the phobia kicks in, this irrational fear kicks in. The book lists all different examples of phobias for you, just to kind of, give you an understanding. People have a constant irrational fear of germs, of even the darkness, of public speaking, so many different types of phobias. And the specific type of phobias can severely impact your daily functioning. And that's what's important to know. The difference between normal anxiety and an anxiety disorder is really when it starts to impact your daily functioning. Agoraphobia. So this involves fearing and avoiding places or situations that might cause panic, and the feeling of being trapped, helpless, or embarrassed. So the client might have a fear of leaving their home alone, that if they go outside, and they have a panic attack, they're not going to be able to come back home. So they don't want to go outside and have a panic attack. So then they don't want to leave their home, or they don't want to leave home without the support of an extra person. They can have a fear of crowds or, lines, like standing in and waiting in a line. What if I have a panic attack in the crowd and I can't escape? I'm going to feel embarrassed. Then my panic attack is going to get worse. So you know what? I'm just not going to go out into a crowd. I'm just not going to go and stand in the line at the bank. People can even have a fear of enclosed or open spaces. It's a fear that you're not going to be able to escape if you have a panic attack. And there are many factors why someone might experience this. So there could be trauma, right? Maybe you've actually experienced some sort of traumatic situation. And then that can increase your risk of developing agoraphobia later in life, right? So maybe you had some sort of loss or abuse or neglect. Or maybe you did have a panic attack in public and you felt embarrassed and you weren't able to leave. And now that's reinforcing this avoidance. There is some evidence that there can be genetic predispositions for anxiety disorders and even panic attacks. That sometimes it can even run in families, right? But once again, that doesn't mean that you're going to get anxiety. There can be the anxiety and panic attacks themselves, right? So the primary trigger for agoraphobia is experiencing panic attacks in public situations. So that in itself, having a panic attack, having anxiety is fueling this agoraphobia, that I already know I have panic attacks. I already know I have anxiety. If I go out into public, I'm going to have a panic attack. I can't escape. So I'm just not going to go out into public. And of course, chronic stress, right? Significant stressful events, grief, bereavement, various forms of assault, even, relationship issues like going through a divorce. All of this can be a trigger for this stress can be a trigger for a panic attack. Next, we have social anxiety disorder. So when it comes to social anxiety disorders, it's this severe anxiety or fear that's provoked by exposure to a social or a performance situation that will be evaluated negatively by others. So the client might fear being scrutinized by others. They fear that they might say something foolish in public, or they might not be able to answer questions in a classroom if the professor picks on them, for example. Clients might even, have a fear of like eating in public. People are watching me. Is there something stuck in my teeth? They're watching the way I'm eating. Even going on stage, right? Social anxiety. Am I going to say something stupid? Am I going to freeze? Are people going to be looking at me? Then you get the heart palpitations, you get the sweating, you get the dry mouth. And fear of public speaking is actually the most common social anxiety phobia. And next, we have substance-induced anxiety disorder. So here we have symptoms of anxiety and panic attacks and obsessions and compulsions we're going to talk about in a little bit. These symptoms, they develop through the use of a substance or within a month of discontinuing a substance. So this could be a substance like alcohol, prescription medications, even caffeine, illegal substances, stimulants, sedatives, cannabis even. It's not illegal, but yeah. So the symptoms the client might experience are, feelings of worrying and fear. They might even, same thing, restlessness. They might experience fatigue, difficulty concentrating. So this can happen while the client is intoxicated and under the influence of that substance. Or it can happen during withdrawal when the body is deprived of that substance. And we'll learn more about substance use specifically in week 9, I believe it is. So, anxiety due to a medical condition, this is when the symptoms are a direct physiological result of a medical condition. So, sometimes clients that have conditions like hyperthyroidism can also experience anxiety because it's related to this primary medical condition. Even like cardiac dysrhythmias and pulmonary embolisms. So, as I mentioned, the treatment for many anxiety disorders is, in fact, psychotherapy, specifically CBT, medication, anti anxiety medications, as well as antidepressants, coping strategies, relaxation strategies, support groups. So, now we're going to get into somatic symptoms and related disorders. So, soma is the Greek word for body. So, when we're talking about somatic symptoms, this is the expression of psychological stress through physical symptoms. So, you have some sort of mental health condition that is now manifesting through physical sensations and physical symptoms. And this can affect men, women, and children, accounting for nearly 25% of primary care clinic visits. So I've even mentioned this previously that when I used to work in primary care, a lot of times I would see clients, older clients, or rather adults, come in, aches and pains. I can't sleep. I'm just worried. Something's wrong with my body. I have difficulty breathing sometimes. Maybe I have a heart condition. My back hurts. My head's always hurting. I can't sleep at night. I keep waking up. I don't have an appetite. Do all the tests, do the blood work, do the x-rays, ultrasound, CT, depending on what the physical complaint was. And everything comes back, quote unquote, normal. It could be a mental health situation, right? Let's examine your life. Let's examine your stressors. And oftentimes people don't think about that, right? In general, the community doesn't necessarily connect the dots between mental health and physical health. And even with children, it is well documented that children do have more somatic symptoms when they're experiencing anxiety and depression. So stomach aches, I don't feel good, I feel really tired. It could be mental health conditions, it could be anxiety, it could be stress, right? So anxiety, depression, and trauma often contribute to those complex psychological and physical experiences. So when it comes to somatic symptoms, we're going to be talking specifically about these various disorders. So before we get into those, I just wanted to talk a little bit about the epidemiology. So specific prevalence rates for somatic symptom disorders in the general population are unknown. And there has been a revision in the DSM-5. So in the past, in order to diagnose someone with a somatic disorder, doctors had to make sure that there was no medical or psychological reasoning that explained these physical symptoms, right? Because you're trying to rule out a medical cause. Is it hyperthyroidism? Is it like a back injury? Is it like a heart condition that's causing these palpitations? So you first had to rule out those medical or psychological conditions that would explain this physical symptom. But now this rule's been removed. So what this means is that a person can have a medical condition and still be diagnosed with a somatic symptom disorder if their thoughts, feelings, or behaviors about these symptoms are excessive or distressing. Okay, so you can still have a medical condition and still have a somatic symptom disorder. And here we're focusing on your thoughts, your feelings, and your behaviors about these symptoms being excessive and distressing and impacting your daily life. So now the focus is not on whether the symptoms are real or imagined, but it's how the person is reacting and experiencing those symptoms. So once again, we're going back to the impact on the client's life. And there are different psychological conditions that can also exist with somatic disorders. And that's the case with all mental health conditions, right? That you don't necessarily have to have just one mental health conditions. You can have concurrent mental health conditions. Like I said, sometimes anxiety and depression, they go together. Client has depression, they might also be experiencing anxiety, but not always, right? We never say always. So when it comes to somatic symptom disorder, this is when a person has one or more physical symptoms. So they could have pain, fatigue, shortness of breath, and this is causing significant distress or problems in their life. So even if the medical condition is present, what makes it a disorder is that the person's thoughts, feelings, and behaviors about the symptoms are excessive or they're out of proportion, right? So the client is in fact suffering. They're constantly worrying about these physical symptoms. They're constantly going and trying to get rechecked. What's wrong with me? What's wrong with me? It's impacting their daily life. So here we're focusing on the distress and the preoccupation that the person has with these physical symptoms, right? So say a client has persistent stomach pain that interferes with their daily life because they're constantly anxious and they're constantly checking their body and they're constantly going to the doctor. They could, in fact, have, say, an ulcer or maybe diverticulitis or, any other stomach condition causing stomach pain. But it's that preoccupation, that's that constant worrying, that constant checking their body, constantly going back to the doctor about this persistent stomach pain. That's what we're focusing on with the somatic symptom disorder. So there is this high level of functional impairment. Illness anxiety disorder. So this was previously known as hypochondria. So here, there's this misinterpretation of physical sensations as evidence of a serious illness. So the client has this over-concerned perspective for their health and they're preoccupied with their symptoms. So with illness anxiety, it can be quite obsessive as thoughts about the illness may interfere and be really intrusive, and it can be hard to dismiss them, even though the clients might realize that their fears are unrealistic. So the client doesn't necessarily have significant physical symptoms, or the symptoms are very mild, right? But the main issue is that they have this intense fear or this preoccupation with having a serious disorder. So say a client has a mild headache for a few days, and now they're convinced that they have a brain tumor. So they're constantly checking, the internet, or they're constantly calling their doctor and saying, I need to get a test, I need to get blood work, I need to get an MRI, I need to get a CT scan, even though having a mild headache is a minor symptom. So I hope we understand the difference here. So with the previous one, somatic symptom disorder, the symptoms are real and distressing, and they're worrying about the impact of the symptoms. With illness anxiety, they might have little to no symptoms, and the worry is about having a serious illness. So next we have conversion disorder. So here the mind converts emotional stress or conflict into a physical symptom, hence the name conversion disorder, right? So a person experiences neurological symptoms that cannot be fully explained by a medical condition. So they might have weakness, paralysis, blindness, numbness, loss of vision or even hearing. But you cannot explain this symptom. You cannot explain the blindness, the paralysis, the numbness, the movement disorders from a medical condition. So the symptoms are real to the person, but they're thought to arise from psychological stress or conflict, not from a physical disease. So the person isn't faking the symptoms, right? So they're not malingering, which we're going to learn about. So they're not faking it. The symptoms are in fact real. People do go blind. They do experience paralysis. They can have a loss of vision. They sometimes even lose their voice and they're not able to speak. But when you do all of the assessments, the tests, this dysfunction, this deficit cannot be explained by a medical condition. So it's thought to arise from psychological stress that's now manifesting as a physical deficit. So as an example, say there's a stressful event that happens and now a person can't move their arm, for example, even though they've had medical tests that show no nerve damage or no muscle damage. Maybe they recently lost a spouse in a traumatic accident and their life's turned upside down. And this stress, this high level stress, anxiety is now manifesting as this deficit where they cannot move their arm. So this is another example of that maladaptive defense mechanism, right? Your body is trying to protect you from this overwhelming trauma, this stressful event, but it's coming up in your body. It's coming up physically. Another example, a person is experiencing some sort of emotionally stressful situation. Same thing, say someone passes away. And now they're experiencing, sudden non-epileptic seizures. And medically, they cannot explain why this is happening. So once again, there's not one known cause, but experiences of childhood trauma, such as physical or sexual trauma, these are common among clients that have conversion disorder. And comorbid psychiatric conditions such as depression, anxiety, PTSD, other somatic disorders, these can also be factors in someone developing conversion disorder as well. So some clients might be really distressed about their symptoms, right? All of a sudden, you can't move, you're paralyzed, you're blind, you can't hear, or you have numbness, whatnot. So it's obviously very distressing, especially when your healthcare team is telling you, well, there's no medical reason why this is happening. We don't know. Others might show a lack of emotional concern. That's what this is referring to, this, excuse my French, the accents, the label indifference. This is thought to be a psychological coping mechanism, right? So the mind is converting the emotional stress into a physical symptom, but by remaining calm and, showing a lack of concern, it's actually helping the person avoid facing this emotional stress directly. And that in turn reduces their anxiety about the situation. So essentially, the body expresses distress physically when the mind appears unconcerned. So your body is still experiencing the stress, but your mind is also protecting you from this overwhelming stress by converting it into a physical symptom. The mind is very interesting, as you are going to learn in this course. So next we have factitious disorders. So here we're talking about a mental health condition where a person intentionally, so that's the key word, they intentionally or deliberately fake, exaggerate, or cause symptoms of an illness, either in themselves or another person, to gain something. So the first one example we have is called factitious disorder imposed on self, previously known as Munchausen syndrome. So here, a client might either fake, exaggerate, or even cause symptoms of an illness on themselves. So with Munchausen syndrome, the primary goal is a psychological gain. So they may want attention, they may want sympathy, they may want extra care, right? So we have situations where clients say they have cancer and they actually go and shave their heads so that people actually think they have cancer. They even fake the symptoms and start to get all these tests, treatments, medications. So they are making themselves sick or they're exaggerating symptoms that they already have in order to gain some sort of psychological aspect, either getting attention from others, gaining sympathy from others. Munchausen by proxy or factitious disorder imposed on another, this is a form of abuse, and this also involves tampering with tests, altering symptoms, and even physically harming the victim, leading to unnecessary medical treatment, severe harm, even injury, and sometimes even death. So the reason that this is a type of abuse is because oftentimes, but not always, it happens with children. It can still happen with adults as well, but you have, say, a caregiver or a parent who tells people that their child is sick. Maybe the child does have some symptoms of an illness, but they might exaggerate them, or they might even cause an illness in the child. So they start to give them medications, for this illness that they say that they have. They start getting all these procedures and tests. Once again, the cancer example, there's been situations where a caregiver says their child has cancer. They actually start giving them medications so that the client starts to vomit, so that they start to have diarrhea, so that they start to feel fatigue and tired. It mimics symptoms of a serious condition. Getting all these tests, getting unnecessary medical treatment and procedures, so that they can gain this psychological attention, this sympathy, care from others, right? I'm just going to skip to the next. Oh, I think I actually took it out. But some examples that I have of Munchausen by proxy, maybe you've heard of it. You can even Google this yourselves. But recently, in the past couple of years, the story of Gypsy Rose, I think her last name is Blanchard, came out. So with Gypsy Rose, essentially her mother, Dee Dee Blanchard, she was able, she was this is an example of Munchausen by proxy. So the mother, Dee Dee Blanchard, was saying that her daughter, Gypsy Rose, has cancer. So she went as far as, shaving her head, shaving her eyebrows so that she looks like someone that's going through chemotherapy. She was able to dupe doctors by saying that her daughter's medical records were lost in Hurricane Katrina, right? Which is an actual event that happened. And if the doctors were asking too many questions, then she would find a new physician, right? She had her daughter, Gypsy Rose, undergo unnecessary medical procedures. such as even removing her salivary glands, right? So she used topical anesthetic so that her daughter would constantly be drooling, right? She would give her medications. She even had, I think, like her teeth removed. So very traumatic, abusive situation. And this is Munchausen by proxy because this factitious disorder, this artificially, deliberately fabricating symptoms was imposed on another person. The mother, the caregiver, was imposing these symptoms on the child to gain attention. And they even got lots of money. And I believe like even a house from Habitat for Humanity and like trips because, there are a lot of organizations that if you do have a serious condition, you're terminal, whatnot, you get certain grants and whatnot. Unfortunately, this is also a bizarre situation because Gypsy Rose then had her internet boyfriend agree to murder the mother. So then Gypsy Rose and the boyfriend actually ended up going to prison and she was recently released, which is why this was in the news again. So once again, you can look at this on your own, but this is just one famous example. Even the rapper Eminem, he's accused his mother of Munchausen by proxy in some of his lyrics. And then the mother went and, sued him for defamation and all of that. That we don't actually know if it happened or not, but this is just an example of real life scenarios. And oftentimes, Munchausen or fictitious disorder, either imposed on self or other, can be difficult to prove. Next, we have malingering. So malingering is a fictitious disorder, and the reason that it differs from fictitious disorder imposed on self or another is because here the client or person is intentionally faking or exaggerating symptoms for personal gain, such as money or avoiding work. Whereas with Munchausen syndrome, either Munchausen or Munchausen by proxy, you're doing it for a primary psychological gain, right? Here, you're doing it because of a personal gain like money or avoiding work, for example. So a client pretends to have back pain after a work incident because they want to receive the insurance money, even though there's no real injury. So the key difference between factitious disorder and conversion disorder. So with conversion disorder, the symptoms are involuntary. The person is not consciously creating them. You have some sort of traumatic event experience, and your body is now converting this extreme stress into a physical symptom. You have no control over this. Whereas with factitious disorders, the person knows they're faking it. And once again, with malingering, the person fakes the illness for external gain, like gaining money or say avoiding work. And the primary motivation in factitious disorder is psychological. So you are seeking attention. You want a sense of importance from your family, healthcare team, whatnot. So next we're going to get into OCD or obsessive compulsive disorders. And OCD is actually the fourth common mental illness. And typically the onset can happen between the ages of 10 and 21 years. So what this means is that there's a tendency for the symptoms to first appear and peak during childhood, so around age 10, and then again it peaks in early adulthood. So males are generally more likely to have an earlier onset than females. And OCD in childhood is diagnosed almost 3 times as frequently in boys than in girls. And in older, or in adults, it occurs with equal frequency between men and women. And when it comes to comorbidity, it can co-occur with other psychiatric disorders. Um, so people can have anxiety disorders with OCD. They can have a mood disorder such as depression with OCD, so on and so forth. But people with only OCD are able to recognize that their thoughts are irrational, though they cannot control them. So I think that's also a common misunderstanding is that people don't recognize that their behaviors are the way that they are. But as we're going to learn, people that only have OCD, they do recognize that their thoughts are irrational, but they cannot control those thoughts. They cannot control those compulsive behaviors, as we're going to learn about. And oftentimes we throw around the word or the phrase rather, oh, I'm so OCD, or she's so OCD, she's so rigid, right? And this is, of course, stigmatizing this specific mental health condition is also taking it out of context, right? Because someone can be very rigid in their ways. They can have perfectionist tendencies. They want things done a certain way, but that doesn't mean that they have the diagnosis of obsessive compulsive disorder. Once again, with a disorder, especially with mental health disorders and anxiety disorder, we're looking at the impairment on their daily functioning. So, quick question for everyone. Is the main symptom of obsessive compulsive disorder excessive hand washing? So the answer is that this is in fact false, or it's fiction. Oftentimes, when we do think about somebody that might have OCD, we might think of them excessively washing their hands. This is one example of a symptom that a client might have, but this is not the main symptom of OCD. Clients that have OCD, not all of them are going to excessively wash their hands. If anyone has seen The Big Bang Theory, even though it's not overtly stated by the writers, there are theories that Sheldon might have obsessive compulsive tendencies. Anytime he knocks on the door, he always knocks 3 times and he says a person's name 3 times, right? So for example, he might be like, Penny, Penny, Penny. So that's one example, right? In media. And once again, media, as I've mentioned, is not always the best example of mental health conditions. They do tend to sensationalize it, they tend to stigmatize it. But sometimes it's also nice to kind of pick out little pieces of things that we might see in media, as it can also help you kind of relate to and understand some of the content that we're talking about. So moving on, when we're talking about OCD, there are 2 features that we need to know about. One is the obsessions. So obsessions are these thoughts, impulses, or these images that persist and recur so that they cannot be dismissed from the mind. So these are thoughts and impulses or images that enter the person's mind and they cannot control that. And this is what causes severe anxiety. The compulsion, the other part of OCD, is the ritualistic behavior that the person feels compelled or driven to perform in order to reduce that anxiety. So you have a thought, you have an impulse or an image that keeps coming into your mind, and this is causing you severe anxiety. So then you are going to feel compelled to perform this ritual in order to ease this obsession that is coming into your mind. However, performing this ritual is only temporarily relieving your anxiety, but you have to perform it over and over and over and over again. So in fact, it is maladaptive. So your textbook also lists various examples, but I'll just point out some of them. So an example of an obsession could be related to contamination. So you keep getting these thoughts and these impulsive, intrusive thoughts that the surfaces in my hand are going to be contaminated with germs, and then I'm going to get sick, and then I'm going to have to go to the hospital. The surfaces in my kitchen are going to be contaminated, and it keeps going over and over again, right? Contamination, getting sick, going to the hospital, contamination, getting sick, going to the hospital, and you can't stop these thoughts. And this is what is causing severe anxiety. So then you perform the compulsion. So you start excessively cleaning your household countertops, or you start excessively hand washing because remember the fear, or the irrational fear is there's contamination, I'm going to get sick, end up in the hospital. Contamination, I'm going to get sick, end up in the hospital. So in order to stop this thought, I'm going to excessively wash my hands. I'm getting rid of the contamination so that I don't get sick, I don't end up in the hospital. Another example of an obsessive thought or impulse, maybe there's a individual has a fear of being responsible. Maybe the client has a fear of harm, right? So maybe they fear being responsible for something terrible happening. And that is a thought that they cannot get out of their mind. So then the compulsion, or that ritualistic behavior, is that they are constantly worrying about being responsible for something terrible happening. So maybe they're worried that they didn't lock their door at night, because if I don't lock my door at night, someone can break in and take all my stuff. So then the compulsion is that they are ritualistically constantly checking their door, constantly checking their alarm. Is the alarm on? You check your phone, is from the app, is the alarm on? Okay, I'm gonna go downstairs and check again. Is the door locked? You're in bed. Wait, did I check the door? Let me go check again just to make sure. So I hope this kind of helps you understand the connection between the obsession and then the compulsion. So OCD is a combination of those two, right? So you have those recurring thoughts and then you have the behaviors. And this is very time consuming and it interferes with your daily life. So going back to that example of someone can have perfectionist tendencies, they can be rigid, they might like things in a certain way, but it doesn't interfere with their life. It doesn't cause time-consuming behaviors, right? So you can still be rigid and have perfectionist tendencies, but that doesn't mean that you have a diagnosis of obsessive compulsive disorder. The treatment, like for many other anxiety disorders, is medication as well as CBT. So OCD is thought to be linked to a serotonin dysregulation. So as a review, serotonin we know helps regulate our mood, our anxiety levels, our stress response, even repetitive behaviors that we do. So with OCD, the circuits in our brain are overactive, right? And this is what leads to these impulsive thoughts, these compulsive behaviors, which is why clients might be given an SSRI, which is the selective serotonin reuptake inhibitors. And this is usually the first line treatment because the SSRIs are going to increase serotonin in the brain, which is going to actually calm these overactive circuits. So there's going to be an effect on the symptoms of OCD because hopefully there will be a reduction in the obsessions, so fewer intrusive thoughts, or maybe there's a decrease in the intensity that they get with these thoughts, which is then going to hopefully result in a reduction in these compulsive behaviors. So they have a less urge to perform this ritual. So once your nervous system is more calm, then you can actually do CBT. You're more effective doing CBT. You're more effective doing the psychotherapy. So usually with the treatment, there's also something called exposure and response prevention, ERP therapy. So usually you are trying to expose the client to these anxiety provoking thoughts or situations. So you're in a supervised environment with the therapist, the client is gradually being exposed to these obsessions, but they're prevented from performing the compulsive behavior. And over time, this is supposed to teach the client that you can actually reduce your anxiety without performing the rituals, right? And that also, as we know with CBT, it's helping us challenge and reframe our irrational thoughts. So medication plus psychotherapy. And this is just a visual of what happens in the vicious cycle of OCD. So you have that irrational, obsessive thought, that impulse, that image that is coming into your mind, which is then causing severe anxiety. Then you feel compelled to perform a ritual to help reduce this anxiety. However, you only get temporary relief, and then the obsessive thought comes back again. So it's this cycle that the client is really struggling with. And then the medication and therapy is supposed to help break this cycle. So once again, we need to review our antidepressants, SSRIs, adverse effects, therapeutic effects, anti-anxiety medications as well. So there are other OCD related disorders as well that we're not going to get into too much detail, but there's body dysmorphic disorder. Here, the client can't stop thinking about, say, one or more perceived defects in or flaws in their appearance, even though the flaw might be minor or they can't even be seen by others. There's also hoarding. So the client feels they have this overwhelming need to save their possessions, and they have an inability to throw their possessions away. And this leads to excessive cluttering and a significant impairment in functioning. I'm sure we've heard of that show. I forget what it's called now. I think it's called Hoarders, on TLC, back in the day when we used to watch live TV, where they actually show, individuals that are struggling with a hoarding disorder. And once again, it's very much related to anxiety, some sort of trauma, where they're now displacing their stress and anxiety onto these objects, right? They cannot let go of these objects because they have some sort of sentimental value to them, and it causes them severe anxiety, right? It's not as simple as, oh, let me just come and clear your house for you, let me throw this away. By you even thinking about throwing some of their belongings away, it can make them go into a full-on panic attack, irrational behavior, yelling. So it's once again, people might like to hold on to things. You don't want to throw it away. Oh, I have this sweater. I haven't worn it in like 5 years, but maybe one day I might wear it. It might come back into style. That's different from maybe someone, your sibling comes, they're like, you know what? You haven't worn this sweater in 5 years. Just throw it away. And you're like, okay, fine, whatever. I'll throw the sweater away. Or you might even be like, no, I want to keep it. But if your sibling does come and actually throw the sweater away, you're not going to go into a full-blown panic attack. You're not going to become erratic. You're not going to, have a maladaptive response. So once again, it always comes back down to the impairment on your daily functioning when we're thinking about these disorders. There's also excessive hair pulling and skin picking disorders, and other compulsive disorders as well. So next we're going to get into trauma and stressor related disorders. And we'll talk about acute stress disorder, PTSD, and dissociative disorders. So with acute stress disorder, this usually occurs within 1 month of a highly traumatic event, and it typically does resolve within 4 weeks, hence the acute aspect of the name in in stress disorder. So usually you have to have some of these dissociative symptoms. So we'll talk about dissociation in a few slides, but when we're talking about dissociative symptoms, we're really referring to this unconscious defense mechanism that protects the individual from overwhelming anxiety and stress through emotional separation. However, this separation results in disturbances in your memory, in your consciousness, in your perception, even in your self-identity. So with acute stress disorder, there has to be at least 3 of these dissociative symptoms that are present. So there's this subjective sense of numbing or detachment or emotional responsiveness, right? There's a reduction in awareness of your surroundings. We've previously spoken about derealization, which is a sense of detachment from yourself, right? I don't feel real. Sorry, the world doesn't feel real. Depersonalization is a sense of detachment from yourself, where I don't feel real. Derealization is where the world doesn't feel real. That was in, I believe, when we spoke about the mental status exam. And then the last one is dissociative amnesia, where there's a loss of memory. So I took this straight from your textbook. This kind of goes through a small case of a 22-year-old university student who experienced a sexual assault. And in the emergency department, she's feeling detached from her body, being unaware of her surroundings, as though the assault took place in a vacuum. She displays virtually no affect. So she's not crying, she doesn't appear anxious, angry, or sad. She finds it difficult to concentrate on the examiner's questions. 3 days later, she still feels as though her mind is detached from her body. She reports difficulty sleeping, not being able to concentrate, and being startled whenever someone touches her. When she sees the nurse 4 weeks later, she expresses feelings of anger, sadness over the assault, displays the ability to concentrate, and states that she no longer feels as though her mind and body are detached. So this is just one example that shows some of those symptoms that we previously spoke about on the slide, on the previous slide. Then there is PTSD. So with acute stress disorder, typically it can resolve within 4 weeks. You know, if the client gets support, especially, that can definitely help. However, it can also be the precursor to PTSD. So with PTSD, this is an emotional response to a traumatic event or situation that involves severe environmental stress. So there can be various examples of why someone might experience PTSD, right? So they could have direct experience themselves. Maybe they've experienced sexual assault. Maybe they've experienced intimate partner violence or DV, domestic violence. Maybe they've been in a traumatic motor vehicle accident. They're either a veteran, a soldier that went to war, or they're a civilian that lived through a war. Maybe they've survived a natural disaster like an earthquake, a flood, a tsunami, a hurricane, whatnot, right? So it's the direct exposure. So they've experienced this traumatic situation themselves. You can also get PTSD by witnessing a traumatic situation. So maybe you saw someone getting shot, or you saw someone getting robbed, or you saw someone, in a physical altercation. You can also get PTSD from learning about a loved one, right? Maybe someone passed away really tragically and traumatically, and hearing those details can also trigger PTSD. Exposure to graphic details in the example of first responders, for example, right? Constantly being exposed to graphic traumatic scenarios can also cause PTSD, right? Abuse in your childhood, whether it's physical, sexual, emotional abuse, neglect, life-threatening events. Maybe there was some sort of kidnapping or a terrorist attack, right? Even if you think about like those who survived 9/11, so on and so forth. Other events, either you heard about them, you witnessed it, or you saw, you were part of it, the sudden death of a loved one. Maybe you were in a plane crash, maybe you were in a robbery, or you saw a robbery, and so on and so forth, right? So various factors as to why someone might experience PTSD. And the major features of PTSD are persistent, as opposed to with acute stress disorder. It usually resolves within a month. So with PTSD, the client might re-experience the trauma through recurrent intrusive recollections. So they might experience flashbacks. And when you're experiencing a flashback, your body literally feels like you are back in that place. You are back in that traumatic, stressful experience. They might even experience nightmares, which is then, of course, going to cause sleep disturbances, right? The client might even avoid the stimuli that's associated with that trauma. There might even be a general numbing, like that detachment we were talking about. There's also increased arousal. So there might be irritability or even aggressive outbursts, right? They might have trouble managing their anger. There might even be some reckless or self-destructive behavior. So the client might even engage in risky behaviors like drinking too much or driving too fast. They might even be hypervigilant, right? They're always on guard for danger. Like in that example previously for acute stress disorder, someone that has experienced sexual assault, in that example we just previously gave, if someone even touches them lightly or taps them, they can become hypervigilant. They can become startled, right? So an exaggerated startle response, right? Being easily startled or frightened, having trouble concentrating, paying attention, difficulty falling asleep or staying asleep, or even experiencing restlessness while you're sleeping. It could be because of these nightmares as well, right? There might even be like negative feelings and thoughts, right? Ongoing fear, anger, guilt, shame about yourself or even the world, right? You can have distorted beliefs because of this incident. You can have a loss of interest, anhedonia, right? Cutting back or losing interest in activities that you once enjoyed. So definitely very serious situation. So I do have a little case scenario here, a little vignette that you can take a look at that kind of goes through these features that we've talked about. So next we're going to talk about dissociative disorders. And like I mentioned, dissociation is this unconscious defense mechanism. And the purpose is for the brain to protect us from overwhelming stress and anxiety through this emotional separation. But this separation from between the mind and the body causes disturbances in your memory, in your consciousness, in your self-identity, in your perception. So on a day-to-day, we can all experience mild, fleeting dissociative experiences. For example, we're listening to someone talking and then suddenly we realize that we didn't hear part of what they were saying, or we didn't hear the full story because we dissociated, right? we just started daydreaming or we zoned out. That's a mild example of dissociating. Or there's something called highway hypnosis, where you're driving on a familiar route. Maybe you drive to school the same route every single day. You know how long it's going to take you. You know exactly, when the speed goes high and the speed goes low. And then all of a sudden you get to your location and you're like, wait a minute, I don't even really remember focusing on the road. So you got there without conscious thought. So that's another example of a mild dissociation that is commonly experienced, right? Or sometimes we become so absorbed in a book or a movie or, a game we're playing that we temporarily lose touch with our surroundings, for example. So these are mild examples that we might experience. However, once again, it's about the severity of the impact on your daily life is what makes it a disorder, right? So the individual's response to stress is impacting their daily life. As we're going to learn about, we've already talked about depersonalization and derealization, but we'll talk a little bit about that briefly, dissociative amnesia, and then DID. And once again, similar to anxiety disorders in general, the treatment for dissociative disorders is psychotherapy, medication, even though the medication is not to cure the dissociative disorder, it's to treat the co-occurring depression and anxiety that might accompany it. Coping strategies as well. So like I said, we have spoken about depersonalization, which is this detachment from the self. You might feel I'm not real, my hands don't feel real. I feel like I'm watching myself from outside of my body. Derealization is the world doesn't seem real. So depersonalization and derealization can happen because of severe stress, emotional abuse, neglect in childhood. It can even happen because of intense stress during a panic attack, even through the use of psychoactive substances. Dissociative amnesia, this is where the client has an inability to recall important information about themselves, often related to a traumatic or stressful experience. And there's something called dissociative fugue. So this is very rare. This is a subtype of dissociative amnesia. So here, the client experiences some sort of traumatic situation and they unexpectedly and suddenly travel away from their home or their work, but they're unable to recall their past. They're unable to remember who they are. So during this dissociative fugue, a person can even assume a new identity. They can engage in normal daily activities in a new place, right? They can even get a new job. They can interact socially, but they have no awareness that they've forgotten their previous life. So when this dissociative fugue comes to an end, and it can last hours, days, or even months or years, the person suddenly remembers their past and suddenly remembers their identity, but they usually don't have a memory of what happened during that fugue, right? So they often experience confusion, shame, distress when they realized what's happened. So once again, this dissociative amnesia is your brain's way of protecting you from this extremely stressful experience that you've gone through. So DID, previously, or dissociative identity disorder, previously known as multiple personalities, this is a very rare dissociative disorder. It's a very rare mental health condition. And here the client has the presence of two or more distinct personality states. So this typically results from severe traumatic sexual, physical, or psychological trauma that occurred in childhood. And once again, as a child, your brain is still developing. And if you go through extreme physical, sexual, or psychological trauma, neglect, abuse, your brain is in survival mode. It's trying to protect you, it's trying to keep you alive. So sometimes clients, once again, this is very rare, the client develops these alters or these alternative personalities. And this is your brain's way of protecting itself from this traumatic situation. So this alter or this alternative personality has its own memories, it has its own personality, it has its own pattern of perceiving and receiving information and thinking about the self and thinking about the environment. They can have their own name, they can have their own accent, they can have their own memories, as I mentioned. So the primary personality is called the host, and they're usually not aware of these sub-personalities. So they might have periods of lost time or unexplained events. They might even end up having clothes in their closet and they're like, how did this get here? Right? So these periods of these memory lapses that they can't figure out, because when they switch from their host, their true self, I guess you could call it that, to their alter, they don't necessarily know that they're switching and they don't have a memory of that alter, that alternative personality. So usually the transition from one personality to another does occur during times of stress, and it can range from a dramatic to a almost barely noticeable switch that happens. Once again, very rare. I've never encountered anyone with DID, but of course the media has sensationalized it. There's a lot of movies and whatnot about people having DID, or previously what was known as multiple personalities. So medications, they're not the primary treatment, but they can address the co-occurring symptoms such as, depression, anxiety. Clients with DID might even experience suicidal ideation, sleep disturbances. This can worsen as well with the dissociation. So the medication is to treat the depression and the anxiety and the sleep disturbances. And the medication doesn't cure or treat the dissociation itself. That's where the advanced practice interventions really come into place. The psychotherapy, the psychoeducation comes into place. And usually these advanced interventions are carried out by psychiatrists or clinical psychologists that specialize in DID. So like I said, for the purpose of this course, we don't need to get into all of that, but we should know what somatic therapy is. So when we're talking about somatic therapy, we're really talking about body-focused therapy that's really trying to help the clients process their trauma and reduce this dissociation. Because remember, soma means the body, right? So with dissociation, there's a disconnect from the mind and the body. So with somatic therapies, you're really trying to ground the client in the present. You're doing a lot of body work to release that trauma from the body, because there's a lot of literature out there that says even though your mind might not remember trauma and traumatic events, your body remembers, your cells remember, the core essence of you remembers the trauma, and it's stored deep within your body, in your psyche. So somatic work, working on the body, helping you connect the mind and the body, can be helpful for these clients. So this we've already gone through. This is really just about cultural safety, cultural humility, being aware of your own biases and values as it comes to anxiety and working with a client that has anxiety disorders, and even what your own beliefs are. The next couple of slides are really about the nursing process. So, of course, we are starting with a general assessment of the client's symptoms. Um, Here, there are a variety of rating scales that you can use. Your textbook has some of them, but the ones that I just wanted you to know about, I posted the Hamilton Anxiety Scale on Blackboard, and your addendum also includes a link to the GAD, the Generalized Anxiety 7. These are commonly used rating scales to help identify, does the client have mild, moderate, severe, or panic disorders? We're also going to be assessing the client's full history, right? So what are their presenting symptoms? So do they have panic attacks? Do they have excessive worrying? Are they restless? Are they engaging in avoidant behaviors? What is the level of anxiety? Is it mild, moderate, severe? Of course, we're doing an assessment of their triggers and how long the the anxiety lasts, right? When do the symptoms begin? How long does the anxiety usually last? What situations trigger the anxiety? What situations make the anxiety feel a little bit better? What's the client's past psychiatric history? What's their medical history, right? Because we're trying to rule out primary causes of anxiety symptoms. Is there a family history of mental health disorders? What about their substance use history? Um, I do have a separate, on the next slide, we're going to talk about the risk assessment, but whenever we're talking about mental health clients, we're always doing a safety assessment, right? Especially with anxiety. We have to consider all aspects of the client's safety. So, are they having thoughts of self-harm? Are they having thoughts about suicide? Are they having thoughts about harming others? For the physical and the behavioral assessment, we're really trying to understand, what are the behavioral manifestations that the client is displaying related to their anxiety. So is it restlessness? Is it fidgeting? Is it pacing? Are they avoiding situations? Are they avoiding people? Are there physical manifestations of their anxiety, such as trembling, sweating, muscle tension, GI upset? And like I said, don't forget to take the vital signs, right? Just because we're dealing with mental health doesn't mean we're just dealing with the client's mind. We have to have a baseline set of vitals, right? Because anxiety can also cause, as we know, palpitations, tachycardia. It can cause hypertension, hyperventilation. So baseline vitals are important. Once again, the MSC, as I mentioned, it's going to keep coming up, right? So here we're really observing the client's appearance and their behavior. So do they seem agitated, tense? Are they hypervigilant? What's their mood and their affect? Are they worried? Do they look anxious or fearful? Are they verbalizing their fears to you? What is their speech and their thought process like? Are they showing rapid speech and racing thoughts? Do they have difficulty concentrating? Excuse me. Their perception and even their cognition, right? Is there a heightened sense of alertness, hyperarousal? What is their insight and judgment like? Are they aware that they have anxiety, but they feel powerless to control it? Psychosocial assessment, we're really trying to understand the impact of the anxiety disorder on the client's relationships, their work, their school, their social activities. What are the coping mechanisms that they're using that are effective versus maladaptive, right? Are they resorting to substances to drown out the noise, to drown out the anxiety, which is maladaptive? What's their support system? Is religion, spirituality, culture important to them? Are there factors that need to be addressed as part of their treatment, right? Of course, risk assessment, as I've mentioned. So we're not going to get into too many details about the nursing diagnosis, outcomes, and planning. You can definitely take a look in your textbook. It outlines some examples for you. So when we are working with clients that have anxiety disorders, we first have to determine what level of distress are they experiencing? So is it mild, moderate, severe, or panic, right? And there are general frameworks for anxiety interventions that can be built on a solid foundation of understanding each level. So, for example, if a client has mild to moderate anxiety, we know that they might still be able to solve problems, right? However, the ability to concentrate decreases as the anxiety increases. So we might be able to help the client focus and, solve a problem using therapeutic nursing communication skills. We can ask open-ended questions. We can explore and seek clarification about the client's stressors. If a client is experiencing severe to panic level type of anxiety, we know that they're not going to be able to concentrate. They're not going to be able to focus on their surroundings. They're going to have a poor grasp of what is going on in their external environment, right? So here we need to know that we need to protect the client, or we have to ensure safety of the client as well as others, right? Because when you're in a panic, you can become erratic, you can become irrational, you might harm yourself, you might accidentally harm someone else. We know that when you're in an extreme level of panic and anxiety, eventually you're going to become exhausted, right? Your system is in overdrive. So we have to ensure that the client's physical needs are being met. Are they hydrated after the panic attack? Are they able to rest? Right? So we can even provide them with a calm, low stimulation environment. Because once again, system is in overdrive, it's overactive. We want to calm them down. We want to place them in an environment that is less overwhelming and less stimulating. And when a client is experiencing severe and to panic levels of anxiety, we want to give them firm, short, simple statements. Long explanations are not going to be understood at this point, right? Also, promoting self-care activities. Some of these I've already mentioned, but focusing on the client's sleep, their personal hygiene and grooming, their nutritional intake, grounding techniques, right? So box breathing, the 5 4 3 2 1 method. So I placed some links on Blackboard for you to take a look at some grounding techniques. But essentially, these techniques can be taught to the client when they are not experiencing anxiety. So you learn these techniques when you're in a relaxed state of mind, so that when you do experience mild, moderate, severe to panic attack levels of anxiety, you can then utilize these techniques that you've learned, right? So this is a skill that takes time and practice, because when you become anxious, one of the first things that goes haywire is your breathing. So bringing your awareness to your breath and practicing things such as box breathing or the 5 4 3 2 1 technique, or even holding ice, right? It brings your attention to the cold in your hands. Sometimes even snapping a rubber band on your wrist can bring you back to the present moment and ground you. There's hundreds of grounding techniques, but I've added some links on Blackboard. Of course, pharmacological interventions, like I mentioned, review what we learned in week 5, understanding why antidepressants are prescribed for anxiety, right? Because they have that secondary benefit of also treating potential comorbid depressive symptoms. And, increasing the level of serotonin, which is going to give you that calm effect. Same thing, understanding why we give anti-anxiety, why we give benzodiazepines, what are non-benzos like buspirone. This is something that you can review. And there's also other advanced interventions that can be used for clients that are experiencing an anxiety disorder. With behavioral therapy, there's different techniques. You can go through it in your book. But modeling is when, say you have a therapist and you're role playing to demonstrate appropriate behavior in, a fearful situation or when you experience a panic attack. So the role modeling really helps you prepare and practice what you can do when you are experiencing anxiety. Systematic desensitization. This is when the client is gradually introduced to the object or the experience that they fear or have that irrational fear of, because over time, um, that object or that experience is supposed to become less frightening because of this graduated exposure, right? So exposure therapy. And the client is also taught relaxation techniques at each step when the anxiety becomes really overwhelming, right? So say you have a client who is experiencing agoraphobia and they have difficulty leaving the house, right? So something as simple as even starting with opening the front door to then opening the door and actually taking a step outside, right? To then going to the end of the driveway, to then going to the end of the street, to then maybe even getting in their car and sitting in their car if they drive, and then maybe even driving down the block or to the end of the street. And this is gradual, right? This can take months, sometimes even years, depending on what the phobia is, and the level of anxiety. Um, Cognitive behavioral therapy, we've already mentioned, so you can go review that. But once again, it's really about understanding the connection between your thoughts, your feelings, your behaviors, and identifying those automatic negative thoughts and challenging those thoughts. Somatic therapy, as we've mentioned, it's about body work. It's about connecting the client to their body and their mind so that they can describe these physical sensations that they're experiencing. Yes. Evaluation, as we've mentioned, it's usually the most forgotten part of the nursing process. Evaluating, is the medication working? Are the client's symptoms decreasing? Is the therapy working? What is working? What is not working? What is helpful? And your goals can change based on that evaluation. So these are the references. I've mentioned the website anxietycanada.com. It has some really helpful tools to understand some of these disorders as well, in case anyone is interested. But thank you so much for listening about anxiety disorders.